In this capture, we're going to examine upper GI disorders. Let's start with the basic review from Foundations, just talking a little bit about nausea and vomiting. Some things to think about: priority concerns, certainly aspiration, particularly in patients who have difficulty maintaining their airway. Perhaps they've recently had anesthesia, they might have a poor swallow reflex, such as post-stroke. We also get concerned with fluid volume deficit, electrolyte and acid base imbalance, particularly hypokalemia and metabolic alkalosis, and certainly symptomatic anemia if the vomiting involves blood in the emesis, hematemesis. Related pharmacologic therapy, your promethazine, Phenergan, and of course your serotonin antagonist, your ondansetron and Zofran. You definitely want to review those meds. Other interventions that can help with nausea and vomiting include environmental control, so thinking about just odors and other things that might cause a little bit of queasiness, relaxation and distraction diversional techniques, cool cloths on the forehead and the back of the neck, and then of course oral care after a patient has vomited. So moving on, just to talk a little bit about hiatal hernia. This actually occurs when a portion of the stomach goes through the hole in the diaphragm that separates the thorax from the abdominal cavity. So you have a portion of the stomach up above the actual diaphragm. This causes a problem because you can get gastric acid up in there. Because of its close proximity to the esophagus, it can cause some esophageal irritation. And it also predisposes the patient to gastric reflux. So speaking of gastric reflux, that's where we're really going to start and taking a look at the pathophysiology of GERD. And basically what happens is the gastric contents reflux through that lower esophageal sphincter back up into the esophagus. After you put something in your mouth, you chew it up, you swallow it, it goes down the esophagus, the lower esophageal sphincter opens, allows it into the stomach, and then the LES closes, and everything should stay in the stomach. When you have GERD, the problem is with that sphincter. It opens back up or relaxes a little bit, which allows the contents to reflux back up. As I mentioned before, hiatal hernia definitely increases the risk for GERD. Now, okay, it's just a little GERD. What's the big deal? Well, the problem is what's refluxing up is extremely acidic. It's hydrochloric acid. Its purpose in life is to digest food. And as that acid comes up into an environment that it's not made for, it actually irritates and inflames and essentially eats away at the esophageal tissue. So long-term GERD, this long-term chronic irritation, it actually causes scarring, the buildup of scar tissue, and narrowing of the esophagus. So you'll get patients that have esophageal strictures, that things can't pass through because it's so narrowed, and they might need to have a procedure called an esophageal dilatation. This also results in actual genetic DNA changes to the cell, and we call that Barrett's esophagus, which is a precursor to the development of esophageal cancer. So risk factors for GERD, once again, gals, we get the short end of the stick. Certainly obesity and pregnancy, both because the additional weight pushes on the stomach. With pregnancy, the developing baby pushes up against the stomach, kind of predisposes you to reflux. Age, we see it a lot in older adults because as we get older, that lower esophageal sphincter, the muscles that control it, are just not as tight and toned as they used to be in our younger days. Sleep apnea is a concern because, again, the pressures will actually cause that sphincter to kind of relax. Certainly, nasogastric tubes, where we're actually putting the tube down through the nose into the stomach, that lower esophageal sphincter never completely closes because of the tube. Supine positioning, particularly after somebody's been eating or drinking. There are also medications that actually, as a side effect, decrease the pressure and the function of that lower esophageal sphincter. So anything nitrates, your calcium channel blockers, your SSRIs, which are an antidepressant. There's also medications that irritate the gastric mucosa, and these also predispose a patient to GERD and it makes the acid that's in there kind of worse when it comes up. It causes more irritation. And I mentioned these in a previous unit. I called them the Fab Four. And here they are. It's aspirin, it's your NSAIDs, potassium chloride, and corticosteroids. These things are definitely going to irritate the gastric mucosa. We'll talk a little bit more about them when we get to the little section on gastritis here just in a few minutes. But those four medications, those Fab Four, they always need to be given with food to try to decrease that risk. So expected findings in a patient with GERD, they'll often report frequent heartburn, some regurgitation. You'll hear the term dyspepsia. They may have dysphagia or difficulty swallowing because of the irritation of the esophagus and throat. Hypersalivation is very common. They may actually exhibit coughing and wheezing just because as the contents reflux up and cause that irritation, the esophagus sits right behind the trachea. So they're actually in pretty close proximity. So you can get some regional irritation that kind of goes over towards the windpipe. Interestingly enough, pediatric patients that experience GERD may often be mistaken for asthma or reactive airway disease because of the coughing and wheezing, when actually the underlying problem may be GERD. It's not uncommon for patients to have a hoarse voice, again, because of that irritation and acid that comes up, hitting the vocal cords. Also sore throat and tooth erosion if it's refluxing all the way up actually into the oral cavity. So when we look at lab and diagnostic testing, a lot of times diagnosis is going to be based on self-report of the symptoms, and the providers will try some medication therapy and see how it works. If the patient responds favorably to therapy, they're kind of given that diagnosis of GERD and we move forward. If not, if they're not getting better or things are getting worse, they may work them up a little bit more. With the CBC, if there is bleeding, either in the stomach or in the esophagus, so you have some of that hematoemesis, there might be some blood in what's coming up. Whether it's gross blood that you can see or hidden blood, microscopic blood, that will show as a decreased hemoglobin and hematocrit. In some cases, they might choose to do a barium swallow where your patient drinks a substance with barium in it. That barium acts as a contrast. They drink it and then radiology takes pictures to see how quickly it moves through and how it moves down through the esophagus, into the stomach, into the small intestine. Of course, there's also the EGD, which is actually an upper endoscopy and upper scope, esophagastroduodenoscopy, where they actually go down the throat and actually visually take a look at the tissue. Something to remember about GERD, and this is really, really important because it seems innocuous, it seems like something minor, but it can turn into a big problem. But the other thing to keep in mind is that signs and symptoms of GERD can often mimic a heart attack. So patients come into the ER reporting chest pain and chest discomfort, and of course the first thing we think about is cardiac, respiratory, because those things obviously would kill your patient first. And once those are ruled out, then we start kind of looking at GI. But it can be extremely painful and very, very uncomfortable for your patient. So from a treatment standpoint, when you think about non-pharmacological things, there's some items we can do nutritionally and then also looking at lifestyle. So nutritionally, anything that we know is going to set the patient off, they want to avoid. It's sometimes helpful to have your patient kind of keep a food diary to see what foods are triggering symptoms. But in general, they want to avoid spicy, acid-based foods. So things like tomatoes, orange juice, chocolate, coffee, milk, and tea can also cause some irritation there. You want to think about the timing of the meals and the snacks, okay? You really don't want to be eating anything within about 3 hours of going to sleep or lying down, because again, that supine position is going to predispose you to GERD. It's recommended that they do small, frequent meals, maybe 6 small meals a day, small snacks a day, versus 3 larger ones. The more stuff you have in the stomach, the more pressure there is in there pushing against that lower esophageal sphincter. And positioning after meals is very important. Patients with GERD should be sitting up a minimum of 30 to 45 minutes after any type of meals or snacks. On the lifestyle side, we know that smoking is a key factor in GERD. To be honest with you, you can do everything else, lifestyle modification, you can do the nutritional therapy, you can do the medications, and if your patient continues to smoke, basically they're wasting their time. That smoking is that powerful of an association with GERD. Weight loss is important. Again, reduced weight, reduced pressure on the stomach and the intestines. Alcohol intake can also exacerbate GERD symptoms, so reducing that is helpful. Avoiding tight-fitting clothing around the abdomen, mainly because it causes some external pressure on the stomach, which then in turn puts pressure on that lower esophageal sphincter. And the last lifestyle modification that's very commonly used is actually elevating the head of bed. Well, that's fine when you're in the hospital. It's very easy to do that. I can push a button and elevate the head of the bed. But at home, if you don't have an adjustable bed, that can be challenging. So what we tell patients is actually to elevate their bed, the top of their bed, if they have a bed frame, on blocks or on wood, about 6 to 8 inches, to kind of be sleeping on a slight incline. And that does help with GERD symptoms, particularly at night. From a pharmacologic therapy perspective, we have several options. Proton pump inhibitors, your PPIs, your histamine 2 antagonists, H2 blockers. Those are both aimed at reducing the actual amount of acid in the stomach. Antacids, they actually neutralize stomach acid. If the problem is delayed emptying of the stomach, we may consider a prokinetic agent such as Reglan, because that's going to stimulate gastric emptying. And also cholinergics may be helpful to try to strengthen that lower esophageal sphincter. From a surgical perspective, and again, this is not typical. Nissen fundoplication might be done if there's a hiatal hernia or if the patient is still having extensive symptoms despite lifestyle, nutritional, and medication. But essentially, they kind of pull the stomach up on itself and wrap it around where the lower esophageal sphincter is and kind of stitch it tight to help provide some stability on that sphincter. Moving on down, talking about gastritis and peptic ulcer disease. Gastritis is just what it sounds like. It's inflammation of the stomach lining, and inflammation to the point that it actually causes a breakdown in the gastric mucosa. Keep in mind, your stomach is meant to digest. It deals with hydrochloric acid all the time. So the cells that are in the stomach are designed to have a very rapid life cycle, a very rapid turnover, and secrete mucus to try to protect themselves against that acid. So if the gastritis is bad enough that it's actually breaking down that mucosa, you have a pretty serious situation. Now, gastritis can be acute with a rapid onset, or it can be more chronic where there's a prolonged inflammation. Chronic is typically related to an H. pylori infection, which is a certain type of bacteria, as well as malignant ulcers. Now, peptic ulcer disease is a little beyond gastritis. This is where you have a breakdown in the mucosa, but it actually becomes an erosion. It creates like a crater. And these can be in the stomach, it can be in the esophagus, it can also be in the duodenum, which is the first part of the small intestine. So what are you going to see in somebody that has gastritis? If it's acute, you're going to have that acute abdomen, the abdominal pain, the nausea, the vomiting. Very sudden onset, very intense. Now, chronic gastritis and peptic ulcer disease symptoms, those tend to be a little bit different. It tends to be a dull, like a gnawing type pain, or even a burning in the mid-epigastric area. With these patients, you tend to see anorexia, meaning a decreased appetite. They may belch a lot. When they belch, they might have that sour taste, sour smell, and also nausea and vomiting. Now, something that's very important to note is depending on the actual anatomical location of the ulcer, The symptoms, the timing of it is going to vary a bit. So if it's a true gastric ulcer, meaning the problem, the ulcer is actually in the stomach, typically you're going to see the symptoms, the pain, 30 to 60 minutes after meals, and the pain gets worse when they eat food. Now, a peptic ulcer, which is typically in the first part of the small intestine, the duodenum, that pain generally occurs about 1.5 to 3 hours after meals. And actually, the pain gets better when they eat food or they have an antacid. So it's really important when we're doing our assessment and we're asking those health history questions and talking to the patient that we gather that information, because it's going to give the provider a little bit more of an idea of what's going on. Now, of course, they're going to do diagnostic testing, and then they can actually pinpoint where exactly the ulcer or the problem is. But we can also get a good idea of what's happening based upon the symptoms. Do keep in mind, and this ties back to Unit 3, patients that have problems with their stomach, especially stomach lining, the stomach cells, if that stomach is not producing enough intrinsic factor to be able to absorb vitamin B12, your patient may actually develop a B12 deficiency just simply because it cannot be absorbed without that intrinsic factor. So risk factors for gastritis and peptic ulcer disease. Conditions that cause excessive secretion of hydrochloric acid. There are some actual genetic disorders that cause this. I forget what it's called. It begins with a Z. Zollinger-Ellison or something like that syndrome, where there's just excessive secretion of hydrochloric acid. Certainly spicy, acidic-based foods, caffeinated foods and drinks, those things can all kind of stimulate that gastric hydrochloric acid. Chronic NSAID use, chronic aspirin therapy, and potassium therapy are all big culprits. Okay, and certainly corticosteroid therapy as well, especially if it's more chronic. So that's why we'll use enteric-coated preparations for the aspirin and also for some of the potassium. That's also why we will give those items with food, okay, to try to minimize that. Again, smoking and alcohol intake are huge factors. I mentioned the genetic family history. And again, H. pylori. It's a type of bacteria that can be found in the stomach, but it is just notorious for stirring up hydrochloric acid and really developing some ulcers and some pretty bad gastritis. So typically, if we're to this point, medication therapy isn't probably working. They're still having symptoms and they're getting worked up. So typically, these patients will have an EGD, an upper endoscopy, and while they're down there, in addition to actually visualizing the tissue, they can take samples and take a look for biopsy. They can also run pH testing and do some other things as well. So treatment. When somebody comes in with an acute flare-up of gastritis or peptic ulcer disease, we're going to keep them NPO. And the reason that is we want the inflammation to kind of chill out. The minute you put something in your mouth, whether it's, food, a drink, or even a piece of ice, signals go to your brain that say, hey, we're getting ready to eat. And it tells the stomach, hey, we're getting ready to eat. So it starts churning out that hydrochloric acid. And we don't want that. We want everything to just kind of chill. So they'll be NPO until those symptoms subside. At that point, we'll begin to advance the diet as tolerated. We'll start very slowly with clear liquids, see how they do before progressing back up. If the cause of the gastritis is something strongly acidic or alkaline, sometimes it's an overdose on certain substances, either an intentional or an accidental poisoning. In those cases, you want to avoid the use of emetics or lavage. Usually you think, well, let's get it out of the body. That can actually cause more harm than good when it's coming back out. So we'll often give agents internally just to try to neutralize it and let it pass through. Pain management is always a concern with this. Depending on the severity of pain, again, you might be looking at some IV opioids. Typically, again, we want to avoid the PO route. Anxiety is also an issue, so again, your IV anti-anxiety agents. We really want to promote rest, both physiological and psychological rest, because any type of physiological or psychological stress is going to stir up that hydrochloric acid. Obviously, we want to avoid the big triggers: alcohol, cigarettes, your aspirin, your NSAIDs, and we're really going to amp up the medication therapy. It is not uncommon for these patients to be on a PPI and an H2 blocker, as well as antacids. Other medications we might use is sucralfate, carafate, and that's all about trying to basically build up that mucosal barrier on top of the gastric cells. And also Cytotec. We'll talk more about those in class, but that one as well tends to have a protective effect on the stomach. So complications from gastritis or peptic ulcer disease. And it is peptic ulcer disease. Do not call it PUD. People will laugh at you. It's peptic ulcer disease. Our three big complications are going to be hemorrhage, perforation, and obstruction. So hemorrhage is exactly what it sounds like. You have this irritation, this erosion, and now it's actually eroded to the point where we hit capillaries, or heaven forbid, we hit a major blood vessel, whether it's an artery or a vein. Symptoms, you're going to see hematoemesis. This can vary from when they throw up, it's like coffee ground emesis, to bright red bleeding. Okay? Big concern with this is hypovolemic shock. And we'll talk a little bit more about this in class, but it's all about supporting airway, breathing, and circulation. Depending on how much fluid, how much blood they lose, if their consciousness, their level of consciousness is altered, we may have to maintain their airway for them. From an oxygenation standpoint, it can be as little as applying nasal cannula with some supplemental oxygen, all the way up to mechanical ventilation. Of course, we're going to have to support circulating volume with IV fluids. They'll have a nasogastric tube hooked up to lavage to suction to pull out any of that gastric bleeding. And ultimately, a lot of times they either need an endoscopic procedure or they need full-fledged surgery so they can kind of figure out and stop where the bleeding is coming from. Perforation, this is where it gets so eroded that it actually literally eats through the complete stomach lining. And now you have an opening either in the stomach or in the small intestine, and the contents from inside those organs are spilling out into the peritoneal cavity. So what you'll see with this is very severe abdomen and also shoulder pain, because everything that's spilling out is going to irritate the phrenic nerve, which also innervates the shoulders. They're going to be They're going to be in severe abdominal pain. They're going to be vomiting. Their belly is going to be tender. When you palpate their abdomen, it is going to be firm. I mean, like board-like. You could bounce a quarter off that sucker. Again, we're worried about hypovolemic shock. Treatment is going to typically involve surgery. Again, all that supportive care that we talked about with hemorrhage. The last complication that we'll typically see is obstruction. And this tends to happen as an ulcer when it's chronically irritated and then healing over and over again, it develops scar tissue. This tends to happen with ulcers that are on the distal part of the stomach, right at the gastric outlet from the stomach to the duodenum. And essentially it becomes obstructed. The scar tissue builds up and it actually blocks off. Since it's blocked, it can't go down, so it has to come back up. Hence the signs and symptoms of nausea, vomiting, and epigastric fullness. Treatment, again, we're going to support them with IV fluids, NG lavage. Let's pull out what's left in there. Depending on how obstructed it is, they might do a procedure called a balloon dilatation. So they'll actually thread the device, a catheter with the balloon on the end of it, down to the part that's obstructed, get it in there and inflate the balloon, kind of try to push open that area that's obstructed. If that's not enough, they may actually need to do surgery. Speaking of surgery, there's two major surgeries that are typically done, and then of course there's variants of these surgeries as well. So rather than get, kind of caught up in what exactly is each surgery, I want you to kind of understand the big concepts of this, and I want you to understand how to take care of a patient who's had stomach surgery and early bowel surgery. Okay. Basically, these two procedures involve the cutting of some of the nerves. It involves removing portions of the stomach and then reattaching the remaining stomach to the intestine, whether it's the duodenum or the jejunum. Okay, so a couple things occur with this. You can see in both pictures they've removed the gastric outlet sphincter between the stomach and the small intestine. What that means is whatever goes into the stomach is immediately going to go into the small intestine. Okay, there's not a whole lot of digestion in the stomach as much because it kind of flops into the duodenum right away or into the jejunum right away. So things to think about with that is food may not be fully digested. Also, depending on what is attached, the duodenum versus the jejunum, your patient may have issues with malabsorption. The small intestine, that's primary function is to absorb nutrients. So particularly with the Billroth 2, if the stomach is dumping directly into the jejunum versus the duodenum, yeah, I'm still getting all the gastric enzymes and the digestive enzymes and secretions from the duodenum coming through, but that food never actually passes through the duodenum to begin that absorption process. So it's not uncommon for these patients to develop malnourishment. So postoperatively with your stomach surgeries, you want to have them in a semi-Fowler position. You really want to watch your pulmonary hygiene. We're very concerned about the development of atelectasis, concerned about the development of pneumonia. So deep breathing, use of incentive spirometry is really important. Again, if they're going to be coughing, you want to splint that abdomen. They generally will come back from surgery with a nasogastric tube in place. As the nurse, you want to note the color, consistency, and amount of the drainage. Many times, these tubes are ordered not to be irrigated, okay? Particularly if it's like a gastric bypass type thing and they've made the stomach much smaller. The concern about this is if you're too aggressive in irrigating and the irrigation comes out and it's right by the anastomosis site where they're connecting the intestine back to the stomach, you can actually rupture that the suture line. So gentle irrigation by gravity only, and that's only if it's prescribed. To be honest with you, if it's not specified in the chart in a patient like this, remember, most NG tubes, you're fine, you're good to go. This is specifically for gastric surgery. If it's not specified whether you can irrigate it or not, that's a call to the provider to clarify that order. And then we're going to slowly advance their diet as they're recovering. Keep in mind what I said about malnutrition. So we may need to provide some nutritional support. And again, because the gut at this point is not really working, we're going to switch to the parenteral route. Pain management is important. Prevention of DVT is important. And of course, interventions to reduce anxiety, because it can be very, very anxiety provoking recovering from these surgeries, particularly if they had a life-threatening occurrence that kind of caused them to be here, like one of those complications. So post-op complication management, we worry about some gastric retention. So typically this would happen if we restarted fluids or food and they're just not digesting it. They don't have good bowel sounds. They're nauseated. We'll switch them back to NPO. Sometimes we'll reinsert the NG tube to low pressure suction to see if that can kind of work its way. Bile reflux is a concern. Because bile is a substance that's made by the liver and stored and concentrated in the gallbladder to come out and digest fats. Again, at the end of the stomach, between the stomach and the duodenum, there's a gastric outlet sphincter that keeps that stuff in the small intestine from coming back into the stomach. Well, if you look back at the pictures from the Billroth procedures, you see that sphincter no longer exists. and you can have bile refluxing into the stomach where it doesn't belong. So if your patient's experiencing bile reflux, we usually treat that with Questrin. Basically, it is a powder that we mix in a water typically, and it binds with the bile salts, and then if it refluxes up, it doesn't cause as much irritation. Malabsorption, I mentioned before, so it's not uncommon for these patients to be on nutrient supplementation, both iron and general multivitamins. Depending on how much of the stomach was affected, they're going to require vitamin B12 supplementation. But again, remember, because the stomach's affected, they don't have the intrinsic factor needed to absorb it, so that B12 would need to be administered parenterally. The other complication we think about is steatorrhea, which is basically fatty stools. Again, because you are bypassing part of the intestine, you're not getting as adequate digestion and absorption of fat. So then that fat is basically removed from your body in the stool. So ways to prevent this are just reducing fat intake and using things like Imodium to actually slow down peristalsis to allow for more absorption, digestion and absorption of these substances. The other big thing I want to talk about is dumping syndrome, and it is, trust me, appropriately named. This happens, again, because we've lost that gastric outlet sphincter, so there is rapid emptying of the gastric contents into the small intestine. Well, when you have, a big influx like that, it's going to cause fluid to come from the intestinal wall into the intestinal lumen. That's going to stimulate like a hyperperistalsis, and things are moving quick. So it causes diarrhea, it causes abdominal cramping, and as a result, it's going to cause a huge influx of insulin to deal with all of that glucose. So then initially their sugar is up when they quick eat, but you have this influx of insulin and then their sugar drops, like a reactive hypoglycemia. Very, very uncomfortable. Signs and symptoms, which you're going to see in the first 30 minutes, nausea, vomiting, they'll be dizzy, they'll be tachycardic, they may even feel palpitations in their chest. And then about an hour and a half to 3 hours later, they're going to get really hungry, dizzy, they'll be sweating, essentially because this is when their sugar is dropping and they are hypoglycemic. So they went up really fast and then they come down real fast, which is why they're having these symptoms. So to deal with dumping syndrome, we want to tell patients to sit in like low Fowler and kind of reduce their activity for at least a half an hour after meals. That's going to help kind of slow peristalsis as well. They should be limiting their fluids, not overall fluid intake, but at one time. So they really shouldn't be consuming more than about 4 ounces of fluid at a time, and they should space those fluids away from their meals. Now that can be really hard because a lot of us eat and drink at the same time. But if you're drinking while you're eating, it's just going to speed the transit time through the GI tract. So we really do want their meals to contain more dry items as opposed to liquid items. You want to eat unsaturated fats as tolerated, kind of keep the carb intake low, and you definitely want to avoid like concentrated carbs and sugars. These patients benefit greatly from just small, frequent meals because, again, we're not taxing the system really big at any one given time. Med-wise, to manage the symptoms, a lot of times they'll be on antispasmodics. They may be on medications that actually delay the absorption of carbohydrates. And that's really important because that can help prevent the severity of the symptoms with the dumping syndrome.